Welcome to the Hands-On, Hands-Off podcast, where we talk about manual therapy with clinicians, researchers, and educators. We are curious manual therapists interested in battling misinformation on both sides. We know manual therapy is not a blanket fix for everything, yet we also appreciate that it can be a valuable tool for many. So, please sit back and enjoy the show as we unravel the complexities of who, when, what, why, and maybe even how to apply or not apply manual therapy. Here are your hosts, Derek Cluley and Seth Peterson.
All right, well, welcome back. This is episode 12 for the Hands-On, Hands-Off podcast for the Duke Centers for Excellence in Manual and Manipulative Therapy. And today we are really excited because we have what I think is one of the premier entities, especially in recent history, for contributions to manual therapy literature and sort of the other research that goes along with what manual therapists do. Louis Pentadora, who is a professor, clinical professor, I think it is, at Baylor University. And we're excited to have you on. Seth and I are pretty stoked to get to ask you some questions and have a conversation. Hopefully others will enjoy this show as well. So with all that said, Louis, would love for you to give our listeners sort of an elevator pitch introduction of yourself, because and this could be the Empire State Building elevator if you want. It's up to you.
Yeah, you know, the older you get, the more you can say about yourself because you've lived a long time, right?
That's right.
But I think, you know, the elevator speech would be, hey, I was born in Spain. That's why I'm able to speak Spanish. I'm fluent in that language. But I was raised in Australia, which is why I sound the way that I do, I think. So I've got a little bit of an Aussie accent, or so I'm told. And that's where I became a physiotherapist and a manipulative therapist. And then in 1993, I had this little whim of coming over to the States and practicing in the United States system and seeing what physical therapy was doing over here. And I've been here ever since, in 1995. So now I'm a triple citizen. I'm an American citizen, an Australian citizen, and a European Union Spanish citizen. So that's pretty cool.
All right, there's more to you, Louis. Come on, man. You left us off in 1993 or 1997. Tell us a little bit more about your academic journey.
Oh, okay. Well, you wanted the elevator speech.
Still going.
Yeah. When I came over here, initially it was just because I felt that manual therapy had become, just me doing like stuff to patients, very passive, and a sole modality. The practice that I was in at the time in Australia was very much, the counter to what I thought would be what's best for patients. And because I was using manual therapy as a standalone thing, I was asking them to do home exercises, but they weren't getting it done. And I thought coming over to the States and having more time with patients, that I would be able to, beef up my exercise prescription and the kinds of exercises that I could do with patients to make it a complement to manual therapy and get better results. And that's exactly what I found, and I felt really good about that. And because I was getting good results, I was getting asked by the clinic where I worked at to teach weekend seminars, teach the other therapists how to provide the manual therapy skills, especially the manipulation. I wanted to teach them dry needling too, but that was still early days and not allowed back then. It got me interested in pursuing a post-professional DPT. And Northern Arizona University had this wonderful offering at the time, around 2004, 2005, where you could do a post-professional DPT by doing electives in various different regions: musculoskeletal, neuromuscular, ethics, professionalism. It was a fun way to do your DPT because it was weekend courses where you'd meet up with some similar like-minded physical therapists that were going through their DPT at the time. And it was just fun. It was so much fun learning that I realized, wow, I think I actually need to step on to the next thing now and look at doing a PhD. And so I ended up going to Nova Southeastern University for a PhD. And that was a hybrid model of a PhD program. So that sort of got me interested in hybrid teaching and realizing, wow, you can learn a lot from home. You don't have to be sitting in a classroom the entire time. A mix of the two is great. I wouldn't like to be learning or teaching manual therapy or physical therapy purely in an online format with never any hands-on, never in persons, a mix. So I think the hybrid model is just ideal because it's a mix of the both. You get to study at home at your own pace, do the things that you want to do when you want to do them, but you still have the requirement of being on campus and meeting with other faculty, meeting with other students, practicing the hands-on skills, doing all that stuff. So that's kind of where it led me to gradually go from full-time academia in a brick and mortar program at UNLV. I was there for 12 years and loved it. Absolutely wonderful place. Still have lots of friends there, which is great. And I'm thinking about them after what happened recently at UNLV. I'm sure you saw that in the news. Pretty shocking that that can happen, but such is life, right? And now I'm at Baylor, and I'm really enjoying the Baylor model of hybrid education because I get to work from home, communicate with students a lot more than I thought I would. I actually have a lot more interaction with my students now than I ever did in full-time clinical practice. I used to have a bowl of candy to try and trick my students into coming into the office to say hi. No, but that was really sneaky. They just sort of walk in, grab a candy and say, "Hi, Dr. P," and then walk out. So they were missing out on the opportunity to just chat for a little while and talk. So that's it.
Yeah, it's an interesting point that you brought up there. I haven't thought about it that way as much, but I could see that being the case. So I have one more question to ask, and I know Seth is like chomping at the bit. I can see him leaning into this microphone here, but I have to ask this question. It's a question I ask all the guests, and it's a well, I think it's a softball question, although most people struggle with this question, I think. So we'll have fun with it. All right, Louis, you're at a restaurant, fine establishment, whatever restaurant you want to be at, and you have you're getting ready to have a seat at the table for 4. Who are the 3 other individuals you would most like to have at that table with you?
Ooh. Whether they're alive right now or not?
People have taken both ways. They could be previously alive.
Okay. Then I think I would love to sit down at a dinner table with Jeff Maitland, Robin McKenzie, and Bob Elvey. They're 3 people that I got to know in my youth. 3 people that had a huge influence in my manual therapy career. Basically persisted and convinced me to do a postgraduate diploma in manip therapy. And when I was in there, I got interacting with them, reading the material, the research that they were doing at the time, the clinical research they were doing, and just the passion that they would demonstrate with their patients. That was just watching them treat patients. I had an instant view of this is what physical therapy should be like. This is a great physical therapist. I want to be like that physical therapist. And I've always aspired to be like them. I don't think I ever will be. They were just too good. But I've done my best.
I don't know about that. I think that if you had dinner with them, I think that they would say, "We're proud of you, Louis, for what you have done." I mean, come on, you guys selling yourself short a little bit there. Definitely have contributed a lot. That's a pretty cool. That's a pretty cool table set. I wouldn't mind being at the table next to y'all. That'd be kind of cool.
Mm-hmm.
You've dropped in.
I would invite you to the table, Eric. You'd come in. Come and join us.
Very nice.
This is actually kind of interesting because I think, Louis, you're the first one to actually pick physical therapists to sit at the table with you.
Mm-hmm.
I don't know if you can just reflect for a minute because, we'll come back to this, but where you are in your kind of evolution and how you've really embraced pain science and manual therapy and maybe some of the rhetoric you hear now. What do you think those physical therapists did that made them great?
Well, I think they were practicing a form of pain neuroscience education but didn't know it. Because one of the things that has come out of the pain science world is that we've got to believe our patients, and we have to, positively reinforce our patients, support our patients, coach our patients, provide patient-centered care. And they were doing that. They were just doing that as part of a natural, this is what I do. And if I asked them, what would you do if, if a patient came in right now, male patient, 34, right-sided low back pain? And every one of them would tell you, well, it depends. Depends on that patient. No one has the same low back pain. And it was funny because when evidence-based practice came in, we started trying to categorize people with low back pain and say, okay, if you have low back pain, you have this cluster of symptoms, and you're more likely to benefit from this kind of manual therapy. You're more likely to benefit from stabilization or traction. We started creating these sort of subgroups, dividing our patients up into groups that would match their interventions, and that seemed like a good idea. But I think we still need that little bit of flexibility to change the prescription, if you like, for the patient in front of us, based on what we see in the patient and what the patient is telling us. And that's something that they did just naturally, without even thinking about it. Jeff was brilliant at the way he would do his unilateral PAs and ask for feedback the whole time. And of course, we're students, we're focusing so much on where our thumbs are. Are we on the right spot? Are we, do I have our hands looking good enough for the professor to say, yes, that's good? We're more focused on our technique and not paying attention to our patient. But those guys, had their sole focus on the patient, worked with them the entire time, and you could see it, even though they wouldn't say anything about it. So I think that's an important part.
It was interesting. I saw Adrian Lowe play a video of Jeff Maitland at the AM conference one year, and it was like he never stopped talking. It was, how's this feel compared to this? How's that? Has it changed? It's been 10 seconds. How's this compared? And and then I've seen you integrate it with the concept of bringing some awareness to people that maybe might have had some central changes. How'd you think about that?
Well, now that I know a lot more, I think differently about it all. One of the things that really helped me clinically for many, many years was Maitland's sort of SINS analysis, looking at the severity, the irritability, the nature of the stage, and helping to prepare you so that you don't overwhelm the patient, you don't do too much to them, so that they feel a benefit from their first visit. That was one of the things that was instilled in me in all of the clinical mentors that I had, was that no matter what, you want your patient leaving you after each session feeling like they got better. They felt better than when they came in. You've done something to help them. It doesn't have to be a huge amount. It needs to be an amount. It needs to be a feeling that I feel better, not a feeling like I feel worse. So that was an important part of it. And gosh, I'm going off track here. And then, that mentorship, that ability to think about that for the SINS is important, because you could sort of know in advance how much to do. And I think the new thing that we add now with pain science is now a P in front of it. So it spins, severity, pain, mechanism, the irritability, the nature of the stage, and the stability. So the pain mechanism is, deciding, is it nociceptive, is it peripheral neuropathic, or is it nociplastic? And, that's some research that's coming out now. And I think that's an attempt to try to categorize your patient a little, based on their pain, their dominant pain mechanism, because it'll definitely guide your treatment. But I still think we need to think about that single patient in front of us, that N of one, as they call it, and make sure that we are able to tailor our treatments for what the patient actually needs and what the patient wants. And I think that's where precision medicine comes in, where you're tailoring what the patient needs, not just what the condition needs. Does that make sense? You treat the patient, not the condition.
It's funny. Yeah, I actually haven't heard the spins thing. I like that because it makes you deliberately think about it. I've heard other people kind of integrate it into the nature section of SINS. But this is, not to, hog the mic from Derek, but yeah, that might be a good segue to this paper that you guys had in JOSPT Open. The title of it was Developing Manual Therapy Frameworks for dedicated pain mechanisms. The lead author was Chad Cook, right? Do you want to talk about how that kind of came into existence and what happened there?
Yeah. Chad emailed me one day and out of the blue, and I got so surprised that someone so well known and prestigious as Chad would reach out to little old me. And he said that he'd love to work with me. He's never had a chance to do any work with me, but he thought he had a project that might interest me. Would I be interested in working with him? And it's a podcast, like. There's a bear in the woods. Yes, of course I was going to work with Chad. So I said yes, and then we talked about the project and what it entailed, and we were talking about frameworks and developing frameworks. And it took a little bit of reading to figure out what it was all about. And then we brought in Dan Rohn as the third sort of coordinator for the group, and then planned it all. And it's amazing when you work with Chad, things get done lightning quick. That project was over. It started and finished at the same time that I had about 17 other projects that I haven't done that are still in the works and going right now. So, yeah, it was a great experience, and having it published quickly in Joe's Petit Open was terrific because it got out and created some discussion, which is fabulous.
Yeah, no, I will second you get on the Chad Cook train and you get on it fast.
Yes.
I was fortunate because I actually had him on my PhD committee, and so that helped me expedite the process. So
that could have been a positive and a negative thing.
Yeah, absolutely, yeah, true, very true. So, question on the spins model, and I'm actually 3 weeks from now I'm getting ready to teach our advanced manual therapy class, and I certainly introduce the SINS model to our students right off the bat because I think that learning that sort of approach to manual therapy is important and essential for all the things that you just mentioned. I assume that actually I don't know if you teach manual therapy anymore. I looked at your what you taught or what you're teaching. It's like anatomy and some MSK courses. But when you're teaching that, or when you guys are teaching that, are you including sort of that Maitland, that SINS approach to care right off the bat? And
yes.
Go ahead and expand on how you guys are doing that.
Yeah. I don't want to take credit for the spins idea because that's a whole bunch of people involved in that. It's definitely one of the key sort of teaching and training points at Evidence in Motion. I teach a couple of classes for them, weekend courses on spinal manipulation to make it safe and effortless, and we include the spins there. I think it's a great idea. The severity and irritability are really that part of that the guideline idea of of triaging your patient. Does your patient actually belong in the clinic with you? Right. So this is the ruling out of red flags and serious other conditions that are not musculoskeletal that may need referral to a physician for further workup. Does your patient belong in the clinic? And this is where the severity and the irritability of the pain can be, the markers that, this is pretty severe pain. It doesn't have a musculoskeletal sort of trigger to it at all. So maybe this is someone who's more sort of, contraindicated for PT right now. I need to refer them on. So this is where the spins comes in handy, because if you add the P into it there, you're discussing what kind of a pain is it? Is it a very nociceptive driven pain? That means that the tissue or the tissues play a more important role. And so you can decide if this is pretty serious, I better get this checked out, or no, this is peripheral neuropathic. It's easier to figure out what's going on, but the nerve root's not badly compromised. It isn't getting any worse, so I may be able to continue on. Or versus nociplastic pain, which is more sort of central sensitization. Yeah, someone can have pretty severe and highly irritable pain, but if it's nociplastic, you still can do a lot with someone like that. Someone that belongs in your clinic, so that you can talk to them about pain and pain signs and help them. Because if you refer them back to a physician, they're going to be medicated and sent off for further imaging and go down a very dark path, in my view. So I think the P, the pain mechanism makes a huge difference. And one of the things that I've always been fighting for throughout my career is the value of manual therapy. And it surprised me that when I started in PT school, manual therapy was on the skids. Jeff Maitland was not really well considered. This is the late 70s at the time. And there wasn't a lot of research out there for the value of manual therapy. And it just was not getting taught in the schools. So when I went through PT school, my orthopedic program was all about exercise. And I guess I didn't pay much attention to it because I didn't do well in orthopedics and had to end up doing a repeat clinical placement in orthopedics, which is the best thing that ever happened to me because it happened to be a manual therapist who taught me some manual therapy techniques. But it goes in cycles, and then it really became a big hit in the late 1990s, early 2000s with the development of clinical prediction rules. Everybody wanted to manipulate, and now we're going through another phase where it's not very popular anymore. In fact, there's a strong media push to say things like manual therapy sucks. And when I first heard that, I thought, you know what? There's probably some truth in that. Manual therapy probably does suck when you suck at it. Because I think it's the same thing with anything else we do in physical therapy. I really sucked at exercise when I was in Australia. I thought exercise sucks. But exercise sucked because I sucked at giving exercises. I sucked at coaching my patients, at convincing them why it was important and showing them how to do the exercises. That's what I learned when I came over here to the States. And it cost me. I had a couple of knee injuries and a back injury. Ended up having injuries with my patients, which was hilarious. And of course, they all wanted to treat me afterwards. Oh, you hurt your back when you were showing me that exercise, Come on, keep doing that exercise with me. It's important. It was a funny sort of experience in a sense. But I really think that that's a strong point. You have to love what you do to be good at it. I mean, if you hate golf, why are you going out there and playing every weekend, swinging at a ball, if you hate it? You would think that golf sucks if you hate it and you don't like it and it's just costing you money and you're frustrated, right? But if you're not, if you actually love it and you can hit the ball straight and you have a great time with friends and you're out there in the open door and there's so many positives to it, then you obviously love it and you become better at it because you keep practicing it. And I think it's the same with everything else, with squats, with lifting, blood flow restriction, dry needling. Manual therapy can suck if you don't put the time in and learn how to do it to the best of your ability. You want to be able to do it to the best of your ability so that the patient that's lying there knows that you've taken the time to be careful, to want to be the best that you can be and demonstrate that to them.
Yeah, I love that, Louis. Yeah, I mean, how do you? I mean, now that we're kind of on this bandwagon talking about this, I mean, how do you make the decision that, hey, I'm going to use, this technique with this patient or this technique with this other patient, given that maybe on the whole, they might work equally well?
Well, it's not exactly true that on the whole it all works equally, equally the same. I think that we as PTs need to critically analyze the literature a little bit better. A lot of those randomized controlled trials that show that manual therapy is no different than usual care. If you look through it all, the studies they probably include studies where manual therapy isn't very well defined, and it can be a mix of different things. It can be soft tissue work, it can be massage, it can be joint mobilization, it can be a muscle energy technique, it can be a high velocity, low amplitude thrust, it can be a low velocity, high amplitude thrust. It can be so many different things, and then if it's that heterogeneous, then how do we expect to manual therapy to be shown to be better at other things? I think one of the really cool studies that came out was by Rowentz and colleagues. I think Josh Clean was on this as well. Derek, you may have been on this study as well. that looked at a meta-analysis of pragmatic versus prescriptive studies.
Oh no, I was not, but I know which one you're talking about. Yeah,
You know
that's
which
a good
one?
Yeah,
Oh,
yeah.
I thought, I mean, just imagined your name there for a second. I thought,
No,
ooh,
I
I think
appreciate
you may
that,
have
but no,
actually
my
been
name
on it.
was not on that one.
Oh, okay. Well, brilliant. They looked at papers, randomized control trials, and they looked at comparison of when people actually got what they were supposed to get in that particular treatment group, allocation group. If they were in the manipulation group, they got the manipulation, and it was a standardized. Everyone gets the same manipulation. Same thing with the mobilization. If it was just mobilization, you only got that. And they compared outcomes, and they found when it was prescriptive studies, manipulation, thrust manipulation versus non-thrust mobilization, in every outcome measure, every time point, manipulation wins. But if it's a pragmatic study, they're both the same. At no point is there any difference between the two groups. I think it's because many people are fearful of using spinal manipulation. They're afraid of actually delivering what's in the treatment, in the treatment protocol. And I can understand that. When I did my clinical prediction rule study for manipulation for the neck, I remember I had one particular patient, and I thought, oh, you're the last person I want to manipulate right now. But she met the clinical inclusion criteria and didn't have any exclusion criteria. It was perfectly safe to manipulate her. She wasn't going to be harmed, but she wasn't going to be feeling any better. I just had this overwhelming clinical sense that this is not a good thing to do to her. But I still had to do it, and my rationale was, well, I got to do it because I need some people to actually get worse. And if people get worse with manipulation, we need to find out what are those characteristics about the patient that tell us they're going to get worse. In other words, there were some characteristics that I saw in this patient that I wish I could verbalize, but a lot of it is just the clinical intuition, that gut feel, the sort of, oh, this is not going to help you. And normally I would pay attention to that and just hold off on the manipulation. Let's do some non-thrust mobilization. We can always come back to it later. One of the things I always tell my students is, hey, if you start off gently, then you can get a bit more, vigorous with your patient once they get to know you and you get to know them. But if you hit them with a sledgehammer on the first visit, they're going to be a bit touchy about you working on them in the future. You've got to, start off slowly. And it's okay to be, weak with your manipulation. If you haven't used enough force, you can always increase it later. And it won't hurt if you've used less force than you needed. But it might hurt if you use too much force, because that's one of the typical sort of findings in manipulation and manual therapy, that a lot of the adverse events tend to occur because way excessive force has been used. Just look on YouTube and you'll see a bunch of really amazing manipulations, right?
Oh, right. So I have a question. I want to kind of go back to Seth's kind of what he brought up, and then I want to use you because you come out of the manual therapy research. You were sort of on the tail end of the heyday of manual therapy research, right? Like, so I think of like the early 2000s, 2002 Flynn, and then Childs was producing some stuff, and we had the Australians producing some things that were saying, no, it's not this, and then Josh Cleveland's doing a few things, Paul Minkin, and then Louis Pentador coming in there, and then I feel like in the last 5, 6, 7 years, there's been a lot of manual therapy research that has been done. So like if we look and we do a PubMed search, it's not that it hasn't been done. It's just that the heyday, I feel like, is a kind of toward its end in some respects. And it goes back to Seth's question. And I think clinically, I think we would all agree that it does matter, right? When that patient is sitting in front of us, it does matter which intervention we're going to choose. That being said, I think part of the rub with research is that ultimately when we start doing studies comparing one approach to another approach, we find a very small effect size. That's expected, because that's just research, and so that's just what's going to happen statistically. So I'm just curious, and I asked this question too because we're actually completing a systematic review on manual therapy for neck pain, and it was just from 2016 on to help us inform the clinical practice guideline. And the thing that I was most surprised about is we actually found 57 new systematic reviews on manual therapy and neck pain in just a 6-year period. And some of that's pulling from original research, and some of that's actually just regurgitating the same systematic review data. But I'm just curious what your thoughts are on like what needs to be sort of the direction of the future of manual therapy. I know that you're dipping a little bit more into pain sciences and mechanisms for dry needling and that kind of stuff, which I know is part of all the equation in clinical practice. But where do we land as to what we need to be researching next? Because I don't feel like we've shut the door on it completely yet.
Yeah.
I don't know. I'm curious what your thoughts are.
Yeah. I don't want to be misknown or misrepresented as someone who just does manual therapy. I'm just a manual therapist. I only manipulate patients. That's kind of like someone saying, "Oh, if you've got neck pain, go and see Louis. He'll manipulate your neck." That's not necessarily true. It depends on the patient in front of me. And I like to think that I am a more eclectic type of therapist. Do I use non-thrust mobilization? Absolutely, yeah. I had one of the best teach me, Jeff Maitland. So yeah, I use that, and I find that very, very effective. But if we're talking about equipoise, then I would say that I'm probably a little bit pushed towards the thrust side, because I've seen how useful it can be initially, how helpful it can be in quite a lot of patients. And what I mean by that is, if you look at a lot of the research, and you compare outcomes using thrust versus non-thrust mobilization, sure, by the end of the trial period, whether it's 2 weeks, 4 weeks, or 6 weeks, there's no difference between the two groups. But manipulation isn't done for 4 to 6 weeks. Manipulation is just done usually in the first 2 or 3 visits, and that's when the difference really comes out. When a patient can be, have much lower pain scores and much lower disability scores. And what that does is create a window of opportunity for them to get better quicker. Now, do they get any better than the non-manipulative group at 6 weeks? Probably not. It's just that group's taken a lot longer to get there. And if it's taken a lot longer to get there, it could be that they've had to take more medications, they've had to take a little more time off work, they're a little slower starting their exercise program, they're a little slower starting to re-engage in life. And there's definitely a socioeconomic benefit to providing thrust joint manipulation or the manual therapy techniques to those patients that you need to demonstrate that they can move, that movement is an important part of their recovery. You've moved them in a pretty unusual way and got some interesting noises out of it, and it felt great. So why can't they move? Why can't they do these exercises? So that's my view of it, really. A lot of the research out there that they're doing now and the systematic reviews that are coming out, some of them are really very selective, and they're starting to realize, okay, maybe I can't group all of these randomized controlled trials, because they talk about manipulative therapy versus a sham manipulation, but the sham isn't a valid sham, or the manipulation is really a manipulation. It's a algorithm of different things. You mentioned before about the heyday of manual therapy when John Childs came out with the validation of the clinical prediction rule, and then Mark Hancock and Chris Marr came back and said, no, it didn't work. Well, of course it didn't work. He didn't do it. They didn't do the manipulation on those patients in Australia. And it was a shock to me, because I thought, what's happening in Australia? And of course, my father-in-law is still a PT and a manual therapist and osteopath. And he was working at the time, and I would often talk to him and say, hey, is it true that you guys are not using manual therapy anymore? What? Of course not. Still using the clinic? Absolutely. Still works very well. Well, the Australians are saying that they're not teaching it anymore in PT school. And he said, yeah, the youngsters are going nuts there. They're too focused on this EBP stuff, evidence-based practice, throwing out their ultrasound machines, and throwing out manual therapy, and exercising everybody. We're going to lose our market share, and patients are going to move on to kinesiologists, to chiropractors, to other people that provide what patients want. I think that's something that we should never forget. We have to give the patient what they want. We have to provide, what's expected. Patient has basic expectations, and if we don't meet them in our treatment program, it's not likely to be a successful outcome. This is where we can bring in a little bit of Louis Gifford and his 4 questions, right? What's wrong with me? How long will it take? What can you as a therapist do? And what can I as a patient do? Make sure you address those 4 answers, and you've had a terrific encounter with your patient.
So let me ask you then, and I know Seth's chomping at the bit to get on the mic here again, but I just got to ask one more question because it goes into your pain research, and you know, certainly in terms of I've no experience of doing pain research at all, but that's certainly an area that you really can't probably be super prescriptive when you're designing studies per se, right? So you have to be relatively pragmatic in the delivery of that. What are some of the, I guess, the nuanced differences between some of the early research that you did with manual therapy, kind of almost the, very prescriptive, your CPR study and maybe a few other studies versus now investigating pain science, and pain science is actually now, I think it's also on its pendulum ride in another direction as well too.
Yes,
but
yeah.
how does what does that look like for you guys as you're investigating that?
Yeah. Actually, the pain neuroscience education research can be prescriptive. Definitely can be prescriptive, but it can also be pragmatic. And it's interesting, I think, when education alone is provided as a difference between the groups, then we end up seeing no non-significant differences in pain and disability after the education. But when it's combined with movement, some sort of movement activity, exercise, manual therapy, stabilization exercises, whatever it may be, train healing even. So education plus something, plus the exercise, the activity, plus goal setting, and plus sleeping, and make sure you address the sleep hygiene aspects of it. As long as those things are included, the outcomes tend to be much better. I'm out of focus here, man. It's bugging me, but you're not going to use the focus anyway. Sorry about that. So that you can be prescriptive, and some of the early studies were because we had one-on-one pain science education, and so we could tailor that education to the patient, but it had to be prescriptive in terms of we had to use the same metaphors and stories. So we had the fire alarm, the nervous system as an alarm system. We had the sensor stories. We had the noisy neighbors. We had some specific stories that would help explain the major features of chronic pain to our patients. And then we got some great results because we saw decreases in pain and increases in ability or decrease in disability. It was when we started doing pragmatic studies where we had patients with total knees, and we gave some of them education and another group not the education. That's when it became a little bit more of the pragmatic side, because then it had to be an education session for a group of people that had or were going to have a total knee replacement. And so it had to be a uniform education for all of them and not tailored to the patient in front there. And I think that showed that there wasn't that much of a difference between the groups because it wasn't tailored to what the patient actually needed. And I think in terms of the education, what we need to do in research now for pain science is to tailor it to the patient in front of them. And they get their pain science stories, they get their understanding of pain, but we also include the pain science education as part of the treatment program and provide the treatment that they need, the exercise activities, the sleep hygiene, and also the goal setting. And we compare that to usual care without the pain science, without the goal setting, without the movement. Well, I've never seen anyone provide usual physical therapy care without some kind of movement activity, but yeah, I think that's where the research is going to go. And also, I think we're starting to look more I'm really focused on the clinical side of things, clinical practice, because I like to provide well, I'm hoping I can help provide some guidance for clinicians. Okay, what do I do with my patient here? What happens in the bench, though, in the actual, sort of laboratories, excites me as well, because there are some great studies that are coming out looking at, the biomarkers and looking at bold level changes of blood flow in the brain during scanning, MRI scanning, and so on, functional MRIs. There's so many areas that we can still look at and learn from. And it's just going to be amazing when we do that sort of study there.
I mean, I don't envy you guys. I mean, it's so tough in my mind. I mean, when you ask the question about where does research need to go, and then we talked about, I mean, to me, it seems, after being in the clinic for a while, you can develop intuition, like you spoke about, Louis. But I mean, there's your clinical equipoise. We mentioned that. There's the patient values, preferences, what they expect when they come in. Maybe even their emotional state that particular day. What are you good at? I mean, just all these different things factor into, plus what does the research say about this specific thing? And then, you got to praise the research, because there's, when they say manual therapy, what did that mean? When they say exercise, what did that mean? Was it pragmatic versus prescriptive? All these different things. And then pain science and, pain phenotypes are coming into the view now. And it's like, dang, there's a lot to think about. And then how do you control for all of that when you're doing a study? It's challenging.
It's impossible. It's impossible, and you have to do your best to look at a very specific little thing to control it as much as possible. I think a misnomer is that we don't really have a lot of randomized controlled trials. We have a lot of randomized trials, but they're not very well controlled. They don't control the intervention. They do control the allocation of subjects to different groups, and they control the time points for follow up, what instruments they're going to use for measure. But I think where they lose that control is the interventions. Are they providing the interventions in a controlled manner? And of course, a lot of the clinical work is, well, you can't do that because that's not the way we do things in the clinic. We don't just use dry needling on one muscle. We don't just manipulate one side of the joint. We don't one side of the neck. We provide things in a package, and so we're trying to provide a similar kind of package. But if it's multiple different packages, then it's not surprising that we get multiple different results. May not be the right package for someone, but it is the right package for someone else.
One of the things that, I mean, one reason maybe I like what you guys are doing with this pain phenotyping thing, is that it at least makes an attempt to tailor the intervention to the individual in their presentation. Can you talk about that? And then maybe, kind of just a broad overview of that kind of table you guys had in that JOSPT open paper?
Yeah, what we asked the panel of experts to do is to come up with, classifications or types of manual therapy. What kind of manual therapy would you do if someone presented with primarily nociceptive pain, primarily peripheral neuropathic pain, or nociplastic pain? And I had the group that did the nociplastic pain, of course. I don't know how I ended up with that, but I did. And the thing that really struck me was how the experts in my little group said, manual therapy has no place whatsoever in nociplastic pain, because the tissues are no longer the problem. So why are you bothering to do anything to the tissues? And my argument was, does manual therapy only do things to the tissues? Maybe manual therapy does more than just move that joint, or not move that joint, or squash that muscle, or stretch that ligament. There are other components to it, and I think that was a really exciting thing about it, because it started to make us realize that you can tailor an intervention for the type of presentation you have. And what came out of that table was that when you have someone who has primarily nociceptive nociceptive pain, so a recent injury. The on-off switch for pain is very obvious. Movements and activities improve or worsen or improve the pain, and there's a consistent sort of, it's the typical outpatient orthopedic PT problem we'd love to see, right? Bending forward hurts, bending backwards helps, so hey, let's do some bending backwards exercises. Oh, that's a lot better. Fantastic. There's where your manual therapy comes in, because there's a direct stimulus response aspect to it all. And everyone agreed that manual therapy, when it's used in that particular framework of pain, that you're looking for within session changes, right? You want the intervention to change something, and if it doesn't, you need to change the technique or strengthen the technique or ease off on the technique, just vary the process a little bit until you get these within session changes. And you're going to be also evaluating a patient between sessions. So they're getting better each time they come and see you, but they're also going to get better immediately after you do something to them with manual therapy. That's not what we expect in nociplastic pain, and it's not what we expect necessarily in peripheral neuropathic pain. In the peripheral neuropathic pain, of course, we've got pain that's in a dermatome, or loss of reflexes involving a particular nerve root, weakness in a myotome. It's the nerve root in distress, radiculopathy, in other words. And this is where the group in that expert panel in that group talked about creating space, movement, and blood for the nervous system. So I was thrilled that they did that, because it was a neurodynamics aspect of manual therapy coming into it. I thought, cool. So we got manual therapy for nociceptive. We've got neurodynamics out of manual therapy for peripheral neuropathic pain. And then in my group, the nociplastic pain, initially the group was saying, no, manual therapy doesn't fit at all. And I thought, wait a second. Yes, it does. Because don't forget, there's manual therapy. Adrian has this lovely slide that I often use as well. And it shows this trajectory of manual therapy along the bottom. It starts over here with the big names, Syriacs and Manel and everything. And it continues on. And out of manual therapy grew neurodynamics, Bob Alvey, David Butler and Michelle Capitiers and so on. And then out of neurodynamics came out pain science. That's where Louis Gifford came out of, and Louis Gifford and Adrian Lowe and David Butler and Lorimer Mosley. It all grew out of manual therapy. So there is a definite manual therapy bent to it. And I think for the nociplastic pain, it can't be telling a patient you're addressing a problem in their joint. It's more about putting your hands on the patient and demonstrating that they can move without pain, that you can move them without them experiencing pain, that it's safe to move, that the things you're asking them to do are going to be perfectly safe, and they're going to make them feel better. Can you use a manipulation in someone with nociplastic pain? Yes, but I wouldn't use it every treatment, and I certainly wouldn't use it any more than once or twice at the most, because then you are buying into the dependency aspect. You're making a point of always doing that same technique because there's a problem at that level. I think you've got to switch it around and make the manual therapy more of a motor remapping or a laterally retraining, a graded motor imagery approach, if you like, to improve the patient ability to participate in the exercise process and achieve goals and so on.
Yeah, that's great. That's actually really fantastic. I'm probably going to incorporate some of this
Please
second
do.
when I teach my manual therapy class. Just to, it's always interesting because I think you're always careful when you're teaching students who are like coming out and expecting the if X then Y, and we throw all these it depends at them, and then to Seth's point, like we have a lot of it depends that goes into it. Even mentoring, I mentor fellows still in the clinic, and we struggle just having those conversations like we're having right now on how that looks. And so I think I would just be curious, like, is this stuff that you're introducing to your Baylor students right off the bat? Like you're getting them into this kind of mode of operation, using the spins, using the pain phenotyping, Incorporating that kind of level of clinical reasoning, or are you kind of like scaling it and kind of like peeling back the layers little by little, and how might that even look? Just curious as a fellow
Yeah.
academician.
We have it threaded throughout the entire program. The faculty got together and came up with a clinical assessment framework, and we felt that there should be a Baylor approach, if you like, to how you evaluate a patient, whether they're musculoskeletal, whether they're neurological, cardiopulmonary, whatever it doesn't matter what the problem is. There should be a standardized way of approaching a patient, right? And we came up with these frameworks, I guess, and a systematic sort of framework and a way for them to do their evaluation that incorporates the spins, incorporates an understanding of pain physiology, but it can be applied to whatever the condition is. It doesn't have to be a spinal problem or a musculoskeletal problem. It can be whatever it is. There's a patient in front of you. So it's an attempt to try to make it more patient-centered rather than condition-centered or condition-specific. The other thing about students is that, and the way that they come in, they're already coming in with some preconceived ideas, and I don't know where they're getting it from, whether they're from their undergrad or from their prerequisite classes. But a lot of them are coming in saying, "Oh, but we all know that manual therapy is not reliable and accurate. There's no accuracy in doing a thrust joint manipulation." And I like to remind them, no, that's not true. There's only one research paper out there, and all that shows is that 28 chiropractors from Canada are not very specific when they manipulate the thoracic spine or the lumbar spine. And if you saw how they did it, you wouldn't be surprised that they weren't very specific, because they didn't even attempt to be specific. Right? You've got to read the research out there. There's very good research out there, and Evan Peterson is one person I think who's done one recently. Suzanne Snodgrass from Australia as well has shown that if there's feedback, if there's time taken and feedback provided by the patient, we are very accurate at localizing specific levels of the cervical, thoracic, and lumbar spine. And even manual techniques for the peripheral joints, we're very good at isolating specific parts of of the major joints and saying, yes, this is a particular problem or this is not a particular problem. We're pretty good as long as we get that feedback from that patient. If it's just a qualitative analysis of how much movement's occurring, is it hypermobile, or normal, we fail pretty miserably on that because we have such variability within us. But when patients guide us, it's much more reliable. And there's a paper in the Journal of Manual Manip Therapy way back in 2018 by Rob Ostendorp. I really recommend people go back and read it. It was called "The Credibility of Manual Therapies at Stake. Where do we go from here?" And Rob's a professor in Belgium. I think he's part of the Belgian Back Society as well. And they've got some great things coming out of there. I think they're reviving manual therapy for the world. It's going to be the Belgian Revolution now.
It all comes out of there.
Yeah.
We're getting close to the wrap up of our time, and I know, Louis, we could talk to you probably for many hours, and we have, and we probably will, and you may be a guest on a part 2 if we ever can get you back on it again. But I appreciate what you just said, though. I think for me, my journey when I went through manual therapy training, the ability to be specific by communicating with the patient was really refreshing, because I was very frustrated when I could not feel what I thought I was supposed to feel and those kinds of things. And to me, actually, that's refreshing to teach the students, because they definitely can't feel that. They definitely don't have the confidence to utilize that sort of skill set to guide their interventions. And I have found that students appreciate that. Oh, it could be as simple as asking them if it gets better, then continue to do that. like that's okay. Yeah, actually, that's great. So, but no, I appreciate that. Seth, I don't know if you have any other wrap up questions or anything that you wanted to toss at Louis in our last 2 to 3 minutes.
No, I think this has been great, Louis. I mean, I think I covered everything. Basically, I wanted to hear you talk about how you treat someone, I think, with nosoplastic pain, and I think I got that. So thank you.
Great.
Yeah, I think
Good.
I've got a few journal reviews or reads that I'm going to pick up on here now too as well. But Louis, appreciate your time as always. Very much appreciate it. I know you're busy, but I look forward to catching up again soon. So
See you at Aon later this year.
we'll
Next
see
year.
you next year.
Not quite
Yes,
year.
next year. All right, thank you, Louis.
Okay. Bye-bye.